Recording. All right.
Yeah, I'll take it away. So can everyone see my screen?
Yep.
Yep, great. Um, so today I'll just have a bit of a chat about cervical spine. It's a little bit more technically complex to get into the cervical spine. It's probably not something that you want to do until after you've done a bunch of lumbers and you're pretty comfortable with all of the with fluid management, hemostasis, hand position, etc., etc. But I'll just go through a little bit about my thoughts of cervical. But just to start off with, I thought I'd just go through a bit of my journey with endoscopy, which has been a very, very long time in the making, and it was just always teetering in the back of my mind as something that I had to get into, but it just seemed to take a long time to get there. I was a registrar in the late '90s with Charlie, and Charlie had this wacky idea of putting a scope down one hole and making a small incision in another hole, and trying to do posterior fossa decompressions. And at the time, we didn't really, it wasn't called anything. It was just called, I suppose, a bit of wackery. But it was that's probably the very first time that I became sort of interested in the spine endoscopy. I was with Charlie for some years. We then tried transitioning from putting in a scope and a separate port to then using it around tumors to see around corners. A few years after that, I had a pretty darn keen and pumped up fellow by the name of Prajanth, and during that year, and Prajanth may have some recollection of this, that when we started doing intradural tumours, we would find any excuse to put in a scope. And to try to look around corners, to look intradurally, upstream and downstream inside the dura. So the concept of endoscopy has always been kind of strong, but then transitioning it to routine practice did take a bit of a jump. The years marched on, and then I had a particularly keen student by the name of Kevin. Prajanth will remember him quite well. And that's really when I first started thinking, okay, I mean, we're going to get into endo. There'll be to stop dabbling and to start doing. And so I got Kevin and a bunch of our students at the time to put together like from what they could get from the literature, a review. And to be fair, and so this was published in 17, but we started this, I suppose, about 10 years ago. And at that time, the literature, to be fair, wasn't really strongly positive towards endoscopy
Right.
and showing a definite
Just if
benefit.
I just stop you for 2 seconds. You
Yep.
remember that Victor Liu, another medical student of ours. I think he must be doing his neurosurgery training in US now.
Yep.
Cool. All right. I'll
Yeah. Yep. And so again, a bit of a start and a stop. And on a personal level, it's something that I dabble with, or at least I'd try and dabble with. But back then, there are no companies, there are no mentors, there's no one really doing it. So it's very, very difficult to get into something when no one else is really doing it. Then about another year or two marched on, and I contacted this guy. Some of you might know who he is. His name is Dr. Camden. I didn't realise what his age was. He was in his mid 80s at the time, and I said, I help run a journal. Can you, endoscopy. I've got the feeling it's gonna grow. It's going to explode. He was in his late 80s at the time, and about 3 months after I contacted him, he passed away, unfortunately. But he did put me into contact with this fella, Anthony Jung. And Anthony, at the time, and his understudy, Lewandowski, I convinced them to put together an entire special submission in JSS on endoscopy. And This, I believe, is the first of the journals that put together a whole submission purely on endoscopy, and there are about close to 40 articles here, and it was a really big win for the journal, and it's been one of the most referenced a part of the and logged into parts of the online. And again, a big call out to Prashant here, who really sort of gave considerable guidance and help along the way to make all this happen. So that was yeah, it's as a personal journey in endoscopy, it's been about a 25-year journey. But it's really been in the last 5 years when it's kind of like when it's kind of exploded, which has been really really sort of filled me with much personal happiness. Um, and if you look at the literature and you put in just spine and endo, you can see that really it is that this as a technique and as a tool is going absolutely nowhere. Is going absolutely gangbusters, and again, myself and Prasanth were pretty darn happy when there's a spike here, and that year is in 2020 when we asked Dr. Camben. He had the audacity to pass away on me, but then Anthony Jung to come along and to spear up that special edition. So it's been it's been one very much of a personal journey, and it's great to see it sort of going gangbusters. The next thing I'd like to just briefly chat about is the concept of biportal and uniportal. And I think that if we fast forward 10 years from now, we'll see trainees getting experience in both techniques. I'm a bit of a uniportal guy myself, but as time goes on, I'm starting to do more and more biportals as I realize that there are a number of pathologies really where, as a technique, it probably does win. And I can see that in the future we do need to support the concept of dual training and dual mastery. And again, Prasanth has just helped me sort of write a opinion piece on this very topic. So whether or not it's a central stenosis, which really this pathology perhaps is better as a biportal in terms of speed of training, ease of training, speed of the intervention itself, hemostasis, etc. This will probably err far more in a biportal direction. However, there are some pathologies that I think that uniportal is very hard to beat. So, for instance, L5S1 microdiscectomy as a transligamental approach to the L5S1 disc, really tough to beat this one as a uniportal. So some pathologies, biportal, interbody fusion, TLIF, central stenosis, especially multi-level central stenosis, where you can hitchhike each of those dual incision points to continue up the spine. But some pathologies as uniportal. And on the uniportal front, I'm going to go into bat by saying cervical pathologies very much, and that's what my talk is about today, as a uniportal technique. So let's move along. When I'm thinking about pretty much my entire practice now is all endo. I just don't do anything open. I mean, I do big stuff open, like big fusions and the rest of it, but and tumors. But I mean, endo is for all decompressive work, irrespective of where it is in the spine. It's for the last couple of years now, especially, it's been pretty much exclusively endo. So, and that goes for cervical pathology. So, if I'm thinking about a discectomy or a foraminotomy, my patient selection is exactly the same as when I used to do something open or with something with a tube. There's just no difference. So, for a disc or for a foraminotomy, a patient with principally unilateral symptoms, an acute disc or a longer-standing foraminal stenosis with disc osteophyte, where arm pain is the principal problem rather than neck pain. Just as a quick pointer, is the bandwidth okay here, folks?
Yep, perfect, Rafe. Thank you.
Right, yeah, good, good. I was just going to show some video, so I just wanted to make sure that it was it was all it was a So whether or not we're talking about a hot disc with relatively symptoms that haven't been there for too long, or whether we're talking about a disc osteophyte complex where the symptoms may have been for months or longer, these pathologies now in my hands are 100% endo. The So I thought I'd just quickly run through a video about just doing a discectomy, just to have a look at the workflow. Is this video changing? As
You
my
just have to
student,
press. You just have to press the button for the.
oh yep, yep, got it, Prasanth.
Thanks.
Okay, mate. Thank you. So here's a nice big juicy C7T1 disc patient presenting with hand weakness. And I pretty much do these. I pretty much do them all as AP X-rays. So for my cervical work, it's for foraminotomy discectomy. It's an AP X-ray every time to pretty much for the whole case. And I base my anatomy on the T1 transverse process, which is a prominent TP, and it's something that's easy to identify, something that's very easy to count upstream and downstream from. So I do all these as AP X-ray. After a needle placement, just lateral to the V point, put in a dilator, a working sleeve, yeah, same way that I do in the lumbar spine or with a disc. And let's just go through some of the steps. So the scope that I'm using here, I call it the mini stenosis. It's an 8.4 scope. It's got a 5.4 working channel, and that gives me enough room to be able to put down basically some of the biportal instruments, such as the RF ablator. And the benefit of using an RF ablator is that you can get very rapid exposure of your anatomy. So here I've identified inferior C7, superior T1. This disc is an upward migrating disc, so I want to see a little bit more of C7 than a T1, and aiming, of course, for that so-called V point that we all know very well. So after docking your working channel, and putting in your working sleeve. I mean, hey, what's going on there? Sorry,
It's okay.
techo stuff. Then using the RF ablator to identify the anatomy, identify the V spot. Then I start drilling on the inferior aspect of the superior lamina, which is exactly the same technique as what we do open. So we start with the superior lamina and we work our way around to the IAP. And that's exactly what's going on here. In the depths, you can see the ligament. I use the RF ablator pretty much for all of my initial exposure. I use it for hemostasis. Here is a angled curette, which has got a slight angle on it that I can just fit down the 8.4 scope. Drilling some more of the IAP to identify the SAP of. Let's just stop that there for a tick. So this is the view that I want to see for doing either a endo disc or an endoforaminotomy. This is the sweet spot. This is the view that you want. And as you can see, that I've drilled principally the inferior aspect of the superior and the IAP. So that's all a safe drill. You're not going to run into problems if you stick with that workflow of the technique of starting with anatomically with those points. So then, now that I'm down onto the SAP, I've disattached some of the ligament that attaches to the top of T1, and let's just keep on going from there. So this is, I think this is a 2 mm, might be 3. No, I think it's a 2 mm Kerrison. The working channel of this scope is over 5 mm, so it affords a fair bit of room, so I can get decent sized instruments. I initially used the interlaminar scope for this, which was a 6.9 scope and a 4.3 working channel. I found I was just too slow, and I'm always in a hurry, so I just had to. I did introduce a larger scope, not the stenosis, but the one down from a stenosis for this surgery. Um, Pretty much stock standard fashion. So this is all the same way that we would do this as an open technique. There's no difference in the workflow. The only difference is getting used to the instruments to be able to achieve those operative steps and that workflow. I usually take that vascular membrane over the exiting nerve root. Now, back in the days of when I used to do this open, this is the part of the procedure that used to really annoy me. You'd get that annoying bleeding from that vascular membrane over the exiting nerve root. You'd swear a few times and hope that it'd magically stop bleeding. It never would. You'd shove a bit of flow seal down there, wait, I mean, blah, blah, blah. The same thing that all of us know and that all of us have done before. But usually with the fluid pressure of not that much, 20, 25, maybe 30, then that vascular bleeding is minimized. And as you can get that super up close and personal view in endoscopy, I love it when you can kind of see, like it's right in your face. You can be super accurate with your hemostasis. So let's keep on going. So just to be certain, the left of the screen is upstream. The right of the screen is the foot of the patient. Top of the screen is medial, and the bottom of the screen is lateral, which is the usual orientation when we're doing endoscopy, whether it's biportal, uniportal. I call it your home view. That's your view of comfort. That's your view where you can look at and know immediately where you are in terms of the anatomical detail. Let's keep going. So I know that this is an upward migrating fragment. So I know that I'm going to find the disc in the shoulder rather than in the axilla, and looks like I'm just widening the exit frame in there a little bit so I can see a bit more of the C8 nerve root. There it is. And again, getting in the nerve into the axilla, the nerve hook into the axilla. This is a big, juicy, chunky disc, so this is very satisfying. One of those discs that we love, that we all love doing. And again, there's nothing different in the workflow here with an open surgery. The only difference is the fact that, well, with the uniportal technique, that your left hand is the workhorse, giving you direction of where the scope is positioned, and for vision. And your right hand is just doing the fun stuff. So it's a bit by bit extracting the disc. Here we are. So we're in the shoulder of the C8 nerve root here, and then getting some hemostasis, and shrinkage of the PLL. So cervical framinotomy and cervical discectomy endoscopically. I'll just have a look to see if I'll just wait until the views. Oh, I wanted just to show something there. So endoframinotomy, endodiscectomy. I keep on kicking myself how little pain these patients have. Compared to even doing this with a tube or with doing it with a mini open with one of those mini Versatrack retractors, the post-operative pain with this technique it is remarkable, and especially as a lot of these patients have Googled this procedure beforehand, and they're all expecting a truckload of pain, and it is just delightful that you either see them later on that evening or the following morning before they go home, and they're absolutely gobsmacked with how little approach-related pain that they have. So that's essentially my workflow for an endo disc or an endoframinotomy. I love this technique. I do it at any opportunity that I can, but really it comes down to being certain about initial docking, which for me is the most stressful part of this intervention. It's where you dock your dilator and where you dock your working sleeve as the as is the tough bit. So in terms of I don't do a lot of lateral X-rays. However, if you're starting off with doing a cervical, if you're starting off with a cervical with a cervical disc or cervical phragmotomy, you may feel more comfortable, especially if you can get the shoulders down, to do part of the procedure with lateral X-ray. I don't use lateral X-ray for this, but in the early days I did more for my own kind of, I suppose, psychology, and to say, okay, well, it's just going to help me understand sort of where I am. So, and initial docking, this looks like it's a 4-5, 1, 2, 3. Yeah, this looks like it's a 4-5 for ammonotomy. A dissector, docking on the V. That's essentially, yeah, that's where the V is. Your initial bony exposure is the IAP and the superior lamina. Then your next exposure is the SAP and the inferior lamina, and then you can, find a nerve and start to do what you got to do. So the so just going through the workflow for a cervical approach. When I dock the needle, I'm aiming for around about the medial third of the facet joint. This is something that I'm certain that I dock right where is safe, and you've got to make sure that the X-ray is orthogonal, and that you can see the midline, and that you know where the V is, because I've still got, I still get a little bit of the jitters when I'm doing this, because obviously you don't want to put it into the interlaminar space. After you've docked that, after you've docked it on that, on the medial facet, and with AP X-ray, and you're certain that you're in the sweet spot, get your working sleeve, pop it down, and then I usually sort of appoint the bevel of the working sleeve medially, so that I'm looking towards the V. Now, people say, okay, well, with AP X-ray, are you sure that you know where you are? And you kind of are. You kind of do know where you are. This is a C4-5. Let's just go through. I mean, this is a pretty shitty X-ray, but let's just go through some of the anatomy. The TP of T1 is a really important, and it's a fixed anatomical landmark for AP X-ray. So I use that as my starting point. I can see the C7 pedicle, C6 pedicle, C5 pedicle, C4 pedicle, and so I can work out where I need to be from there. So next of all, actually, I'll just speed up here a little bit, because it's so just to go through the workflow again. I do an initial dock. I don't kind of dock mid facet. I'd probably dock sort of more medial third. Identify the V, and you use that using some form of radio frequency. This exactly the same with open surgery. I would then drill the superior lamina and the IAP. That's a very safe drill. You're not going to run into bad mojo doing that, because you're protected by the ligament medially, and you're protected by the SAP of the lower level laterally. So this is a pretty rapid. You can be a little bit gutsy with your drilling here. Then to drill the inferior lamina and the SAP, obviously you need to be a little bit slower and a bit more cautious here, because beneath you is going to be the neural elements, and then you follow the nerve. So that's a phragmotomy. That's a discectomy. So I do also do my cervical laminectomies endo. It's a little bit. I'm not going to lie, a little sphincter tightening. It's not something that you want to take on early on in your practice. At a guesstimate, I'd say, this is not something that you're doing until after you've done it. Really, I would say a couple of hundred cases, or maybe at least 100 cases, because you need to be at that level of expertise where you're not thinking about your hand movements, you're not thinking about fluid management. you're smooth with hemostasis. You can get away with operating with low fluid pressures, and it does take time to get to that level of smoothness. So this is not something. This is not an early stage career intervention. This is a far more down the track stage. So here's a patient that I did a TDR on about 7 years ago. He's got developed a bad osteophyte behind the C3-4 TDR. Next level down, he's got a bit of disc osteophyte complex. It's a pretty bad myelopathy actually. He's presenting and he's not in a good way. So because I want to do a C3, C4, C5 up to the top of C6 laminectomy, I dock at the midpoint of those landmarks. And I try and dock as medially as what I feel safe to do. After I've docked, so this is using an 8.4 scope. This is not the stenosis 10 scope, but then again, it's not the interlaminar 6 or 6.9 scope. So it affords me a bit of room to be able to put in decent sized instruments and to be able to be fairly speedy with doing the procedure. So this is at C4-5, I think. Yeah. So there's the spinous process, lamina, at the bottom of the screen, the facet joint. And then I'm basically just doing it as I would start doing a foraminotomy. Identifying one level and being certain about my anatomy and my decompression at one level. I know it's getting a bit on, folks, so I'll just sort of speed this up a little bit. Actually, what I might do is I might get to here. So we're still at a single level. We're at C4-5 here. This is a 5 millimeter diamond tip burr. The working channel of this particular scope is 5.4, so you can get down a pretty juicy sized drill bit. So this is a 5 drill bit. And again, when I started doing these with the smaller scope, and it was just taking me too long, and I was getting too frustrated, and so I've been able to drill out a unilateral approach at C4-5, identifying the ligament. And again, the concern here is that your working sleeve, this little puppy, is going to slip and plunge into the operative corridor. So when you're doing these procedures, it's this is a 3 millimeter kerrison. So when you're doing these procedures, I'm constantly I'm conscious about the position of this fella and making certain that it's either docked just lateral to the neural exposure. This is not a quick operation. These doing laminectomies endo, it does take a bit of time. But if it's done systematically, cautiously, it's something that you can introduce into your toolbox. So this is a three kerrison. I use two forms of radio frequency. There's the RF wand. That's for rapid exposure, rapid hemostasis, rapid tissue clearance, etc. And then when I'm getting down to the more detailed stuff, I will use one of the single probes. Yeah, I call it the nose picker. Yeah, you can, but it's a far more focal form of a hemostasis. So this is a 3-level laminectomy that can be done down as a single stab, but again, it's commensurate with your level of experience and your level of comfort with your scope handling, etc. So just to demonstrate that multi-levels can be done down a single stab. So this is down to C6 here. I won't go through the entire C6 and all the way up. And after you get down to the level of the of where you need to be, you can see that I'm rotating the working channel to try and get the best angulation and the best view. These scopes are either angled at 15 or 30 degrees, and so then you can to help you look around corners. So, folks, there's cervical endo in 30 minutes. It's midweek, so I've been trying to keep it short, but please fire any questions that you want at me, and it's a and just on a very personal level, it's been a really it's been a really good fun journey with especially with Prajanth. Some years ago, we were dabbling in a bit of this and a bit of that and a bit of biportal and a bit of any portal that we could get our hands on, and it's been and it's for both of us it's been awesome to see endo really explode. Thank you.
Thanks very much, Rafe. That was fantastic. I've got a couple of questions if others don't have any at this point in time. That's fascinating about the usage of just pure AP, Rafe. That's fantastic. I never thought about it. I've done it for C7 T1 because you can see it straight up.
Yeah.
But for the others, I haven't. So that's a very good point of AP X-ray. I always worry about being in the wrong level.
Yeah, yeah. That's a fair concern. So I mean, I at the top of the spine, C12 is pretty clear and definitive, and at the bottom end of the spine, the T1 TP is a very clear landmark. So irrespective of if you're in the top of the neck or the bottom of the neck, level identification can be is pretty safe using those two principal sort of pointers, and especially at the bottom end of the neck, that T1 TP is it kind of stands out.
Fantastic.
Thank you. Hi, this is Shanu. Thanks
Hey,
for
all right.
excellent presentation and thanks, Prashant. I just have a quick comment about the X-ray as well. I was just recently in Seattle and talking to all these endo gurus in US as well, and they are about to publish this 45-degree X-ray. So we have the AP and lateral, but at 45-degree view, the shoulder side of the way and the odontoid process, the C2, we can see quite clearly as well. And it's quite nice to count down in a 45-degree view as well. So that's just another way, another technique that I learned recently. I totally agree. I think just the initial operating at the correct level is the key for this operation. And I found that 45-degree X-ray was quite helpful.
Oh, that's
Yeah,
fantastic, Shane. I think
yeah.
I remember this. The pain physicians used it for RF.
Yeah, just have a look next time when you're doing the case, just to see what view you get at 45-degree. You can nicely count all the lamina, clearly see the facet joints and count from top up as well. But I routinely use bottom up AP as well. Yeah.
Oh,
Yeah.
fantastic. The next interesting thing, Rafe, was using the 8.4 scope. Do you use the same scope for your lumbar cases?
Yeah, so so as far as the uniportal scopes go, so the scopes that I use, so there's a 6.3, 6, 9, 8, 4, and 10. So I found that with cervical foraminotomy disc, I was getting a little bit frustrated with the 6.9 scope. So that's got a 4.1 working channel. So you can get in the small drill, you can get in the 2.5 drill.
Yeah,
But I just, I mean, I mean, Prajanth, you know me, I'm always in a hurry, and I was getting frustrated at the time it was taking me to do these take cases.
yeah,
So I did. The 10 scope is just too big, so I didn't want to go to a stenosis scope. But there's a nice transition point, and the 8 scope is actually it's a nice transition scope whereby you can still get down a big mofo drill and really sort of do your bony foraminotomy pretty quickly, and also I can get down the RF probe for that rapid soft tissue clearance, especially in cervical. I find that initial soft tissue clearance can be a little bit annoying because it can just take your time and
yeah.
where am I? Oh, there's still muscle and a bit of ligament in the way, and you get frustrated and you start to want to speed up your soft tissue clearance. Um, so the reason why I transitioned to the slightly bigger scope is for speed of initial clearance of the anatomy, and so I can get a bigger drill down there.
That's the interest because there was I was at a conference about 2 years ago, I think, where one of the guys was just using 8.4 for almost everything because it's not too small, it's not
Yeah,
too big, and then it's a good size to do almost most of the work.
yeah. Yeah, it is. I mean, on the downside, out of all the scopes I've busted over the years, the 8.4 happens to be to be the one that I've busted the most. Um, I'm I don't know why, but it's the one that I've had a few issues with from. But I mean, every scope is going to bust eventually, and yeah, maybe it's just because I'm using that particular scope a lot.
The third question before, if anybody else doesn't have, is the craniocaudal angle that you go for your cervical foraminotomies. Does it
Mm.
make a huge difference in terms of whether you're like almost AP upside down, like straight up and down, or just slightly angled along the facet of the
Yeah,
index disc?
yeah. So I thought someone was going to ask me that, so I put up this slide here. Um, so I mean, what we like to do is to come in perpendicular,
Yeah,
and I mean that makes us feel most comfortable when we come in perpendicular, especially if we're doing something open. It makes sense to our brain if it's perpendicular. We can appreciate, understand the anatomy. The When I'm doing them AP, I don't think that I'm ever coming in perfectly perpendicular. But I really don't think it makes any difference at all because with the angulation of the scope, and the fact that you're basically like right there, like that you and the anatomy is like is a millimeter away, is I don't think it really matters that much, and so with the rotation of the scope and the rotation of the working sleeve, you really can get quite. I don't think it actually makes that much of a difference. I do try and line up the II where I think is around about perpendicular to the neck,
yeah,
but I don't think that I ever get that sort of truly perpendicular approach.
fantastic. Do any of you got any more questions?
Hi, Ralph. Can you hear me? This is Mark Lam from
Oh,
WA.
hi, Mark. Mhm.
Hello.
All right.
Just regarding what you say is much more difficult. So is it the docking that's difficult, or what is the actual? Is it the
Yeah,
drilling because it's so close to the cord and
yeah.
there's a little margin of error that makes it more difficult?
Yeah. I suppose anything with the neck we get a bit more worried about. So, but for me, it's actually the docking and putting downward pressure on a dilator. You want to be certain that that dilator is docked onto something safe. So, I mean, over time, I've become far more comfortable with putting a needle, K-wire, incision, dilator. But even so, out of all the parts of this procedure that I'll do the most X-rays, it's at the start of the procedure. Obviously to get the right level, but also so that I know that my docking is going to be safe and that I don't slip into the interlaminar window. Um, so that's yeah. So then the second bit of why it's a little bit more worrying for me is the initial radio frequency. I used to use the little one, the little what's it called, trigger flex, the single point RF to do the soft tissue dissection. I just found it just took me too long. So that's why I did transition to a slightly bigger scope where I can put that far more aggressive and far fast, like the RF wand, to get that initial exposure of the V point and the bone much quicker. Really, the drilling part is something that I'm least worried about because if you start on the superior lamina and the IAP, it's actually a really safe drill. Like it's hard to stuff up there. It's hard to plunge. It's hard to It's hard to do anything bad there because if you, I mean, if you plunge, if you plunge and you're a bit medial, you're going to plunge onto ligamentum flavum. If you plunge and you're a bit lateral, well, you're going to go through the IAP onto the SAP, bone. So that initial drilling for me is safe and rapid and aggressive. Then after I've done that, so let's find that. I'll
So
just
how do you avoid drilling too superior or inferiorly into the pedicle? Because like when I do it open, you kind of see where the theca is, and you kind of follow the theca, follow the nerve
Yep.
visually, but you're relying on drilling over the ligamentum for the endoscopic technique to avoid kind
Yep.
of doing any dangerous drilling, right? So,
Yeah. So I suppose if you're slightly medial, like I mean, can you all see that picture?
mm,
Yeah. So if you're slightly medial and you're drilling through the bone and you land on ligament, then you know that you're in the interlaminar window. If you're
mhm,
slightly lateral and you're drilling, and then you hit bone on the other side of it, well, then you know that you've drilled through the IAP and you're hitting the SAP of the level below.
mhm,
So really, it's kind of what I'm drilling down to is, I suppose, is the key for where I am in that in relation to the V. Um, um,
so you start drilling actually almost like mid lateral mass, kind of.
oh no, no,
Uh,
I actually start drilling pretty much right where the V is now, like right where
okay.
the two,
Yeah.
the superior lamina and
Yeah.
the inferior lamina meet.
Yeah.
I try and start drilling right there. Yeah.
Okay. Yeah.
And but I'm drilling the superior lamina first, of course. And then, like in that video, I sort of drill until I can see. I've got a nice bed of ligamentum flavum in front of me, and then I
Mhm,
went a bit more lateral to drill out the IAP,
mhm,
or at least part of it. I suppose I would take probably about the medial third, or probably medial quarter of the facet joint.
mhm,
Um, I think that's around about, yeah, that's probably around about what I take.
mhm,
Yeah.
mhm. So you sometimes you do it for obviously for facet up hypertrophy causing foraminal stenosis. So is that you have where you have to drill a lot? Because that's certainly in my experience in the open case, with
Yeah.
very big facets that you're not even sure where you're drilling.
Yeah. Yeah. No, no. Yeah. I know what you mean.
Yeah.
Well, I suppose in that instance, you could use an AP X-ray to see where you are. Yeah.
Hmm.
Yeah. So you can put like a dissector, or a hook, or something down there. So you can take an AP X-ray, see where you are in relation to the pedicle.
Mm-hmm.
If you can see where you are in relation to the pedicle, then that's going to give you an idea of where you are in relation to the exit foramen.
Hmm.
So if you're just slightly medial to the pedicle, you'll be at the takeoff of the nerve root. If your dissector is sitting on pedicle or lateral to pedicle, well, then you'll know that you'll be a little bit, that you're coming in down onto the foramen that's a bit, more lateral, and you may be coming down onto the nerve root itself. I still like saying that nerve root, the thecal sac and the nerve root exit. I still like seeing the shoulder and the axilla of the nerve root. Psychologically, if I haven't seen that, I get a bit worried. Yeah, and that I just that's my comfort zone. That I want to see the lateral dura,
Mm-hmm.
nerve root, shoulder,
Mm-hmm.
axilla, and then just follow it out as far as what I think it needs to be followed out. And as we all know, this is not it's almost like a bit of a subjective procedure, isn't it? Like you drill and you feel it until it feels about right. But
Mm-hmm.
for me, there's no objective, point of where I say, yep, it's definitely
Mm-hmm.
done. So it's more of a gut feel thing.
Okay.
Um, yeah,
Okay.
all
Just
good stuff.
two more questions, right? One is the inevitable question of fluid pressure in the neck and its issues, if there are. Um, that's probably one of the main things. And the other things is the nerve root is depending on where it is. Is it, we're at 3-4 or you're C7-8-1, the angle of the nerve root could be quite different.
Yep. Yep. Irrespective of the angle, I mean, if I'm doing a disc, I want to see if the disc is at the level, the herniation is at the level, or it hasn't migrated up a little bit, or down a bit. But despite that, I still try my best to make certain that I've seen the shoulder and the axilla of the nerve root, irrespective of if I'm at the top or the bottom. Um, and one of the great things with endoscopy is that you can rotate this. You can get really close to the nerve and rotate the scope upstream, and you can see the pedicle. You can see the superior pedicle. Rotate your scope downstream, see the inferior pedicle. So the vision of the nerve root with endoscopy far beats anything that you can do open. I mean, anyone who tells me that the vision is better using a microscope, I mean, it's that is simply not the case.
Yeah,
Your vision of the neural anatomy endoscopy is it far outweighs any recollection I have of when I used to do this open. But yeah, I mean, you're right. Although the position of the nerve in relation to the disc does alter somewhat as you go up the neck, my personal approach to this procedure is still to see the shoulder and the axilla in every case.
fantastic. Um, I think my last question was about the fluid management, Rafe.
Yeah, now
Okay.
that's a really good question, Prajanth. I mean, I have to sort of, I have to fess up and be honest about my experience. I have had a cervical laminectomy who did get a bit worse post-op. Um, did bounce back, but didn't bounce back to their baseline, which was a bit devastating for me. And in that case, I mean, I was absolutely particular at running the pressure low, 20 to 25. Um, Being really meticulous and cautious with the hemostasis, being really certain that the bevel of your working sleeve is docked on bone, and isn't going to plunge into the canal. But fluid pressure for necks, I try and run 20 to 25. Fluid pressure in the lumbar, I'd try and run 30 to 35. However, with the initial exposure and you're on bone and there's no nerve exposed, I actually don't matter how high I go. I go up to 40 or 50 for that first initial clearance and yeah, bony clearance. And when I'm doing a lot of the drilling. So if you're not inside the canal, you can run the pressure pretty high. It probably doesn't really matter. But when you're in the canal in the lumbar, I go 30, 35, cervical 20, 25.
Yeah. Do you think the issue that comes out is not because the fluid is not coming out? Is it because there is like a valve mechanism somewhere along the compression elsewhere, not where you're operating, just at this next level, or just more higher up where the water is getting kind of blocked by this valve mechanism?
Yeah, now that is a really good point, Prajanth. I mean, fluid management is almost its own separate discussion.
Yeah.
I've had two patients with postoperative seizures with a duotomy, and despite having we tried hard to keep the pressure super low. I think that you're absolutely right, Prajanth, that you can get a valve mechanism of the fluid going in and starting to increase the pressure, the CSF pressure within that, within the corridor of CSF all the way up to the head. But thankfully, both of those patients have had normal recoveries. But there is a concern where, especially with a duotomy, and a lot of the time we don't notice that there's a duotomy, right?
Yeah.
It's not like there's fluid coming out. There's fluid going in, but there's not fluid going out. So sometimes you don't know that you've got a duotomy. So I mean that is one of the these are one of the things that we're learning in endo as we do it, right? I mean, and the rule of thumb there is that drop the pressure to as low as what you feel as though that you can,
Yeah.
for hemostasis. And in lumbers now, if there's no bleeding, I'll drop it to 25, 20.
Yeah.
I mean, the machine that I use only, I mean, it bottoms out at 10, like there's no zero, like it's 10 pressure, which is almost nothing. Yeah, so good hemostasis, just drop the pressure as low as you can.
Yeah.
That's the simple rule of thumb that I've got.
Fantastic. Rafe,
Yeah.
thank you so much for your wonderful talk. It was really fantastic.
Yeah. Oh,
Thank you.
and Prashant, mate, a huge call out to you for for organising this teaching gig, mate. That is exceptional stuff. And also as a as a friendship, and as we've both gotten into endo over the years and been doing more and more, it's been a great ride. And I can guarantee you in 5 or 10 years' time, when endo's become, well, we already, I mean, you and me think it's the gold standard and the standard of care. But as it gradually more transitions into being the standard of care, it's been a really good fun ride. So, mate, thank you.
Thanks, everyone.
Thanks, guys.
Cheers,
Thanks,
Rafe.
Thanks,
folks.
guys.
Bye.
Thank you.